Very good evening and warm welcome, everyone. And I hope my voice is loud and clear, and I hope there are no disturbance around me. And with this, we are going to start our dermatology. In just a second, we are going to begin our dermatology lecture. And this is actually for our subscribed students. So I just wanted to give a glimpse of it for everyone who is even not subscribed so that you will understand some basics and you will be also benefited from it. Okay. And I hope all of you had listened to my core concept lecture, dermatology lectures, and there I had described everything in detail. But here, what we are going to do is we are going to learn some basics, just the basics of some basics in the form of some terminologies. Okay, some terminologies in the all right. This is going to be like for another 15 minutes like that. And then immediately after learning the terminologies, we are going to do MCQ sessions. Okay. I'll work out around 1/4 of MCQs for everyone here. And rest of the 3/4 will be done for the subscribed students. All right. For the subscribed students, where we will be covering all the three major QMACs. Every single question from there asked in dermatology, including your PP, PM, OE, I believe this words will give you a clue exactly what question banks I'm talking about. All right. With this, without wasting further time, we will go into dermatology. All right, straightforward. Some of the primary morphology of the lesion, you should be macule, patch, papule, plaque, nodule, vesicle, bulla, pustule, erosion, and ulceration. You should know the definitions of this. Then only you will have an idea what exactly it is. For example, if you see something like that of a cutaneous leishmaniasis, it's going to form an ulcer. All right, it's going to form an ulcer. For example, if you take herpes, herpes will form vesicles. Right. If you take psoriasis, it forms your plaques. Like that, I can keep going on. All right. So you should be knowing, okay, you should be knowing which particular condition forms what. So for that, you should know the basics. Unless if you don't know the basics, we won't be able to understand. Then we will be fumbling around the dermatology. Because part 2 will have pictures. I don't know the quality of the pictures they're going to use. Because during our time, long back, they used to give printed pictures in a piece of paper. And that used to be so pathetic. All the small pictures will be zoomed out to a nearly of an A4 size, and it will come pixelated and it will be terrible. Now I think you guys have examination on the computer throughout the world. So I believe the picture quality will be good and picture quality will be better. Okay. And I would also say this is a very right time to enter UK because next 4 years, there are a lot of doors open. You can enter and you can try your way, fight your way to get settled down in one or the other job. And after that, there are worse times coming where going abroad itself is going to be very challenging. So utilize your maximum chances of going abroad in the next 4 years. At least till 2028, you have some doors open. All right. Okay. With this, we'll start with the very first thing, a macule. What is a macule? A macule is a flat, even its surface. It is even with the surface level of the surrounding skin. If this is the surrounding skin, macule will be like this. It won't go up or go down. Okay. It's even with the surface of the surrounding skin or the mucous membranes. Okay. And precipitable only as an area of color. Only thing you will find is a color difference. This is a macular lesion. What you are seeing here is a macular lesion. All of you can see this. Is the slides visible? This is a macular lesion. Okay. Next comes a patch. What is a patch? A patch is a macule and is a flat area of skin or mucous membrane with a different color from its surrounding. This patch has slightly different color from the surrounding. This is again like a macule. But see here, see this. This is a patch. This is a patch. And this again is a patch. This patch has a different color from its surrounding. And these patches are about more than 1 centimeter. Okay. These patches are about more than 1 centimeter or larger in size. This is called as a patch. Next is papules. What is a papule? Papule is an elevated or a depressed lesion. Remember, it can be elevated or it can be a depressed lesion It is less than 1 centimeter in size. These are all your papules. Okay. These are all your papules. Okay. Next comes a nodule. A nodule is a palpable lesion. Nodule is a palpable lesion that is greater than 1 centimeter with a domed or spherical or ovoid in shape. Okay, you don't need to know the different types of nodules. That is for people who are going to appear for specialty certificate examination in dermatology. But at least know these are called your nodules. These are your nodules. You will come across conditions like, nodular basal cell carcinoma, all these variants you will get. You will get nodules in many other conditions, okay? Subcutaneous nodules, all these things. So this is a definition of a nodule. Then comes a plaque. What is a plaque? Plaque. You will get something like, a plaque psoriasis. So you should know what is a plaque. Plaque is a solid plate-like elevation or a depression with a diameter of more than 1 centimeter. See here, these are all your plaques. These are all a group of plaques, scattered plaques all across the abdomen's anterior surface of the abdomen and chest. Then comes vesicle. You will get vesicular lesion, especially where and all you will get. You will get in a herpes. You will get vesicular lesion in a bullous pemphigoid. A vesicle is a fluid-filled papule smaller than 1 centimeter. If it is larger, it is called bullous. Bulla. Where you get these lesions in your bullous pemphigoid. See, these are vesicles, small vesicle. When the vesicles are larger, okay, measures about 1 centimeter or larger, this is what you call as your, it's a bulle and this is a vesicle. Okay, this is a vesicle and this is a bulle. This is a pustule. A pustule is a circumscribed or raised papule in the epidermis. This is a pustule. This is a circumscribed lesion. Again, pustules you will get in case of a pustular psoriasis. You will get in case of a pustular psoriasis. You can find a lot of pustules. This is a pustule. Next, other miscellaneous terms which you should know. Crust describes a dried fluid on the skin surface due to serum, blood, or a combination of both. You will get crust in lesions like impetigo. Am I right? Impetigo. The type demonstrate. The type is told as they'll typically give a definition of honey crusted lesion. They'll give a definition of something called honey crusted lesion. Then come lichenification. You will get in lichen planus. It's a thickening or accentuation of the skin. This is called your lichenification. Then comes atrophy, Then comes a fissure. Fissure is a linear loss of continuity of the skin surface. Okay, if this is a skin surface, if the continuity is lost, it's called a fissure. Where will you get a fissure? You will get fissure in anus. We call it as anal fissure. So many fissuring conditions are there, which we will come when we discuss the individual conditions. Then some of the diagnostic signs. There is something called your apple jelly signs. Okay, apple jelly sign. Okay, what is an apple jelly sign? Just a second, I'll just change the color. Okay, a yellowish hue produced from pressure on the lesion. Typically, it is seen in any granulomatosis. Then there is Asbo-Hansen sign. That is a lateral extension of a blister. Okay, lateral extension of the pressure blister in a downward pressure. Then there is an Auspitz sign. Okay, then there is Auspitz sign. Auspitz sign is a pinpoint bleeding on top of ruptured capillaries. You can find in psoriatic plaques. If you just started scratching your psoriatic plaques, you'll find pinpoint bleeding. That's what we call as an Auspitz sign. Then buttonhole sign. This is seen in neurofibroma. If you press a neurofibroma, it will give a depression like a buttonhole. It's called buttonhole sign. Then carpet tuck sign. You can find when the horny plugs at the undersurface of the scale are removed from a lesion, especially in chronic cutaneous lupus, you can find them. Then Darrier sign. Darrier sign, in this, apple jelly sign has been asked, Auspitz sign has been asked, buttonhole sign has been asked as a direct MCQ for you. Then comes Darrier sign. Again, this has passed. Darrier sign is nothing other than a tricarial wheal produced in a lesion after it's firmly rubbed with the finger or the rounded end of it. You can see some dermatologists just they will rub the lesion that will cause an atricarial wheal production. Seen in Atricaria pigmentosa, you can find them in histiocytosis and many other conditions. All right. Then your Nikolsky sign is something that is asked. If you laterally give a pressure, laterally if you exert a pressure on an unblistered skin, okay, this will result in shearing of epidermis. This will be seen in all blistering disorder. I'll show you some pictures, you will understand better. This is an apple jelly shine. This is a yellowish hue that is produced on a lesion when a pressure is given. See, if you take a, let's change the color again, just a second. If you take a glass slide and if you apply the glass slide on a lesion and give a pressure, for example, if you see in cutaneous sarcoidosis or in any granulomatous process, there is an yellowish hue will be there. This yellowish hue, if you get, this is an apple jelly sign. Then Albright's dimple sign. You can find this in Albright's hereditary osteodystrophy. You can find this patient videos and everything in my endocrine lectures. It is in MedExpert platform in YouTube. Okay, in my endocrine lecture in pseudo hypoparathyroidism. There is a patient there. I describe this lesion in a patient. You can go ahead and find it, where there will be absent of fourth and fifth knuckles on a clenched fist. Then comes your Asbo-Hansen sign. Okay, this is the extension of blister into the unblistered skin. Okay, here is the blister. Applying pressure, the blister will extend into the unblistered skin. This is typically seen in toxic epidermal necrolysis and as well as pemphigus vulgaris and bullous pemphigoid. All this thing, you will see this Asbo-Hansen sign. Then this classical Auspitz sign. Okay, Auspitz sign. It's described in psoriasis. These are the bleeding points. These are the bleeding points, especially in case of a plaque psoriasis. Okay, plaque psoriasis. Removal of the stratum corneum, removal of the Buckley's membrane will produce bleeding points. This is called your Auspitz sign. Okay, this is called your Auspitz sign. Then there is something fascinating called breakfast, lunch, and dinner sign. This you will find in case of a bed bug bites. Okay, throughout its meal. Okay, it will, if for example, if this is your skin, it will take a meal here and here and here. All along the path, it will leave some lesion. This is called a breakfast, lunch, and dinner sign. Then this is a buttonhole sign, which I said in neurofibromatosis 1, otherwise known as von Recklinghausen disease. All right, this is knuckle and dimple sign, which we have seen. All right. If there is a short third metacarpal bone, then it's mostly a Downs. Fourth, you will see in Turner's. Fourth and fifth together, you will see pseudo hypoparathyroidism. All right. This is the structure of a skin. Epidermis, dermis, and hypodermis. Dermis is further divided into papillary and reticular dermis. Hypodermis is there below. All right. Hypodermis is there below. Okay, and epidermis, layers of epidermis has been asked in MCQs. It is stratum corneum, stratum zetum, stratum granulosum, stratum spinosum, and stratum basal. Basal is the basal layer, corneum is the top layer. This questions has been asked for you. All right, this questions has been asked for. Okay. Then different fungal organism and the morphology. This is for more for tropical medicine people. They won't ask you. So with this basic introduction to the terminologies, we are going to work out some MCQs together. Okay, you will have a taste of what's happening in our actual classes for our subscribers. You also going to be a part of it today. We will be working out some MCQs together. All right, just give me a minute for changing the screen. Yep. Here we go. I hope all of you can hear me loud and clear. Now we are going to work out some MCQs together. Okay, we are going to work out some MCQs together. This is how we work out our MCQs. We teach the basics, then we teach all the core concepts, each and every dermatological condition individually. What is the latest diagnosis, diagnostic criteria? How do you diagnose that? What is the first drug of choice? What are the drugs that is contraindicated? Everything in and out we used to see. Then after that, we used to sit and work out all the MCQs from all the Q banks for our subscribers. And then also we do give some grant test, and then we have 200 MCQs. First time we are introduced 200 MCQ sections. Okay, because past test, to be honest, has only 100 MCQ recalls from past papers. We are starting with a 200 MCQ recall. That means entire MCQs based on the entire recalls, not just we are going to be limited to 100 MCQs. So after this mock, all the 200 MCQs will be discussed individually by different mentors. This time I'm taking charge. Probably by next time, I'll be moving for part 2, and I will be there for part 1 as well. And pace is also coming up from us. So this is how we are progressing. So without wasting much time, we are going to start our very first MCQs. Here it is. A woman recently diagnosed with acute myeloid leukemia presents with a rash 3 weeks after completing chemotherapy. When it comes to working MCQs, okay, when it comes to working MCQs, please try to mentally underline the important points. I don't think you will have the luxury of underlining anything in a computer, but mentally note down the points that is needed, like how I'm noting down. She is febrile and she is leukopenic. A macular rash is noted on the trunk with several vesicles. Previous serology was VSV, varicella zoster virus, is positive for IgG. What is it first? She is an immunocompromised individual because she is on a chemotherapy and she is leukopenic, she is febrile. Now, over the trunk, she develops a band of vesicles like this. And she is VSV IgG positive. This should give you a clue to the diagnosis. What is the diagnosis here? What is the diagnosis here? Is it A? Is it B? Is it C? Is it D? Or is it D? Please,
C.
doctor, type in the chat to be better, because this is being recorded live. Please type in the chat. C, A. Who said A? How chickenpox occurs? You know the symptoms of chickenpox. Have you seen chickenpox in your day-to-day clinical practice? How they come? Recently, I've just like treated a person who is 14 years old. He came with chickenpox. What are the complaints? Doctor, my eyes are red. My nose is leaking. My eyes are watering. I'm feeling febrile. My joints are paining. And I have a rash all over my trunk. This is a classical chickenpox. Here, there is a fever is there, but there is a macular rash that is noted in the trunk. And she is VSV IgG positive. She already had a viral infection and developed antibodies. So it's not chickenpox. This is not how it presents. HSV infection won't spread as a particular vesicles just over the trunk. It can be anywhere. Again, parvovirus infection, you know how it presents. Typical slapped cheek appearance, erythematous appearance on your cheek. Who said D? D is not the answer. What is ORF? What is ORF? ORF will tell you how the history will come. Some farmer, okay, you assume this is a cow. Some cow farmer will keep, milking the cow or playing with the cow or feeding the cow. Then all of a sudden one day in his finger, he will develop a nodular lesion. It will keep growing slowly. This is an ORF. What you are seeing is a multi-dermatomal shingles. Okay, this is called your shingles. And the treatment is you have to give IV antivirals. In UK, preferably, we give acyclovir, IV acyclovir. I just told how chickenpox presents. Another doctor is asking why it's not a chickenpox. I just explained. Please rewind the video, and I explained everything. All of you are clear? I told why it is not chicken pox, why it is not HSV, why it is not RF, why it's not parvovirus. I told how all these diseases will present. All of you got it? Clear? I'll go to the next question. Okay, 25-year-old man is presenting with recurrent nocturnal convulsions. Okay, recurrent nocturnal convulsions. He has cafe au lait spots on the buttocks. Clinical examination of the nervous system is completely normal. His CBC, normal, electrolytes, RFT, LFT, normal. ECG showing sinus rhythm. Which of the following would provide a diagnosis? First thing, you should know what is the diagnosis here. Okay, what is the diagnosis here? Cafe au lait spots. Let us dissect this question one by one. Okay, one by one. Cafe au lait spots get present in many conditions. The conditions that are interested when it comes to MRCP examination is neurofibromatosis. Another is, anyone can tell me? McCune-Albright syndrome. Okay, McCune-Albright syndrome. Two things can produce cafe au lait spots. All right, the next thing is cafe au lait spots with nocturnal convulsions. Okay, nocturnal convulsions is more in favor of neurofibromatosis, typically NF1. All right, NF1. Okay, later they will develop full-blown manifestation of neurofibromatosis. So, which of the following would provide a diagnosis? A CT scan of the brain may or may not provide a neurofibroma in the brain. May or may not. It's still not diagnosed. You can rule that out. Next, a cutaneous biopsy of the buttock lesion. Really? What is there in his buttock? You can see only cafe au lait spots. Okay? Cafe au lait spots. So cafe au lait spots, by biopsying it, you are not going to get anything. So EEG, if some person has a seizure, definitely it is going to give some polyspike and wave discharge, dyspareuthmias, or discharge from temporal lobe or frontal lobe. All these things you will find in an EEG. But EEG is still not going to give you a diagnosis. All right, echocardiogram is not going to be obviously do any help. But slit lamp examination of the eye in case of a neurofibromatosis type 1 will make you see something called as your Lish nodules. These Lish nodules are nothing other than your Irish hamartomas. Okay, Irish hamartomas. Regarding neurofibromatosis, you should know the criteria for neurofibromatosis. So many MCQs are framed on that, and PACES examination, almost every examiner I know, they are asking this question. What is the criteria for neurofibromatosis? Okay. And next thing, you should know how it presents the clinical features, difference between neurofibromatosis 1 and neurofibromatosis 2. You should know the investigation. You should know the management. All these things. And you should also know the close differentials for the cafe au lait spots, that is McCune-Albright syndrome. Okay, McCune-Albright syndrome. Now let's go to the third MCQ. A 45-year-old gentleman, okay, gentleman is present to the emergency department. He has been recently on a 2-week holiday to Spain, where he suffered erythema, blistering, and bulle formation on sun-exposed skin. So anything sun-exposed skin leading to erythema, blistering, or bulle is called your photodermatitis. That's the overall umbrella term for that. It's called photodermatitis. He has no past medical history of note. He drinks around 40 units of alcohol per week and smokes 10 cigarettes per day. Typical Britisher, nothing to wonder. Where the skin has begun to heal, it's only healing slowly. It's itchy, hyperpigmented with formation of milia. On examination, the BP is 135 by 72 millimeter of mercury, and pulse is regular, and extensive skin blistering is seen in sun-exposed area. Okay, without moving to the next slide, what are the possibilities here? Sun-exposed area. Without moving to the next slide. Excellent, Dr. Myra, excellent. And Dr. Razia, good. Dr. Maria, good. It's PCT. Okay. By studying this, you should get to the diagnosis. You need not go to the investigation. Investigation here, see, they are given porphyrins plus, but not everywhere you can see like this cakewalk, like piece of cake like investigation, where they will come directly and give porphyrins are present in the urine. No, sometimes they won't give you. But seeing this, you should be able to make a diagnosis. This is porphyria cutanea tarda. A very, very important condition. Okay. This is a very, very important condition. Porphyria cutanea tarda. So many times this has been asked in MRCP part 1 and as well as part 2. Both in part 1 and part 2. So many other things you should know. It can also precipitate onycholysis. Okay. Next thing, it is due to deficiency of urodenzyme, that is uroporphyrinogen decarboxylase deficiency. All right. Uro and decarboxylase deficiency. There can be also hypertrichosis. Okay. It can also cause hepatic fibrosis. Okay. It can also cause hepatic fibrosis. So typically you will find porphyrins in the urine, and also this PCT is associated with hepatitis C and hemochromatosis. All right, hepatitis C and hemochromatosis. Okay, all these things can be. And treatment, if they ask you, you can do phlebotomy. You can give low dose antimalarials. Okay, low dose antimalarials or something you can give low dose antimalarials. Why I am writing all these things is anything can be asked. They can just give a scenario of onycholysis and fibrosis and ask you to diagnose something. You should be able to do HPCT. They can give a scenario of PCT and they can ask you which enzyme is deficient. You should be able to tell. They can give you the entire scenario and diagnosis. Then they will ask you what is the treatment you will give. You should be able to tell. So you should be able to equip to answer anything they will ask you. And PCT, the associated conditions they may ask, that is Hep C and hemochromatosis. Okay, this is PCT. Now the question is, which other step likely to be most successful in reducing the severity of the skin condition? A, B, C, D, E. What is the most successful thing you will do to reduce this gentleman's skin condition? Some doctor is asking PCT full form. PCT is porphyria cutanea tarda. Okay, you want me to write here? This is PCT means porphyria cutanea tarda. Also nephrology, PCT means proximal convoluted tubule. What other PCT? Anyone remember? Please tell. Okay. Question already I've shown, doctor. We are little running out of time, so I'll be just going. Only thing. What is the thing you will do to reduce the severity of the skin condition is avoidance of alcohol. Alcohol exacerbates porphyria, and in patients with Hodgkin's lymphoma, if they drink alcohol, they will have pain. Alcohol exacerbates so many other conditions. Not even a drop of alcohol is good for you. Okay, that's avoidance of alcohol. Coming to the next question. A 42-year-old man with a history of diabetes mellitus presents with a large lesion on the left shin. Okay, over time has become scarred and yellowish in the middle. On examination, you are seeing a 6-centimeter lesion on the left shin. The center of the lesion is waxy, yellow, atrophic, with prominent blood vessels and evidence of ulceration. The edges are red-brown in color. He is bilaterally having peripheral neuropathy and doesn't report the area as being particularly painful. A painless lesion in diabetes. A painless yellowish, waxy in shin, lesion in shin in a diabetes is nothing other than NLD, necrobiosis lipoidica diabeticorum, unless proven otherwise NLD. Okay, this is a classical necrobiosis lipotica diabetica. Okay, it's a very rare thing, but you won't find in all diabetic people. Okay, even my endocrine consultant, he used to tell, I hardly come across something like a necrobiosis lipotica diabetica. Also, one thing, it can occur in many autoimmune arthritis also, not just diabetes, autoimmune arthritis also. There also it can occur. Okay, there also it can occur. And the treatment, when it comes to treatment, is mostly good glycemic control. Then you can give some Piva therapy, you can give. Then you can give intralesional triamcinolone. Okay, intralesional steroids you can try, but nothing is curative. All right. Yes, that's necrobiosis of lipotica. Next, 45-year-old man known to be alcoholic presents to the clinic with severe dermatitis affecting the face and legs predominantly. He also admitted of chronic diarrhea, increasing lethargy, with extensive dermatitis, with some evidence of ulceration and crusting, particularly where he scratched himself. His nail shows evidence of nail bed infection and hair loss. What is it? A, B, C, D, E. What is it? What deficiency leads to this? Let us see one by one. I'm sorry. Yeah. Let us see one by one. What are all the problems? Dermatitis. Diarrhea is there. Okay. And lethargy is there. And what exactly is there? There is something very peculiar about this. This dermatitis is ulcerating and crusting. There is also nail bed infection and hair loss. Okay, let us rule out here. Let us rule out a couple of things. Let us rule out a couple of things. Phosphate, it's not going to cause anything as such. Magnesium, no. Ascorbic acid. So all are left with two options, niacin and zinc deficiency. Okay, zinc deficiency. And nail bed infection, what is the term we use for nail bed infection? Nail bed infection is called paronychia. If you remember, the nail bed infection is called paronychia. And what else is happening here? He has extensive dermatitis and he has some hair loss and he has some alopecia and he has diarrhea. All right, he has diarrhea. These features associated with alcoholism is more in favor of zinc deficiency. I know a lot of people will be jump into pellagra, but all the components of pellagra is not met. All the components of pellagra, other component of pellagra. What are the components of pellagra? What are all you will see in pellagra? What other components you will see? What are the three things? 4 Ds they will call. Diarrhea, dementia, dermatitis, and final D is death. Okay, the final D is death. You should find all the components and you should be able to correlate. And also remember, MRCP examination can have more than one right answer. Okay, more than one right answer. And pellagra's, pellagra's rash as a typical distribution. For example, if this is somebody, okay, just can I erase it? All of you note it down. Okay, pellagra's rash, for example, if this is somebody's head, it will be around the neck. Okay, it will be around this gentleman's neck, like a necklace. It's called Casals necklace. Okay, it's called Casals necklace. All right, all these things will be there. This is a classical pellagra rash. Pellagra rash is not going to come Pellagra rash is not going to come on nails, but near the zinc deficiency, it will cause paranoia. So you have to rule out all these things. Then you will get the answer. It's a zinc deficiency and not pellagra. Pellagra can also cause cardiomyopathy. Right? 54-year-old. We come to the next question. 54-year-old woman who lived many years in Kenya comes to the clinic for review. She suffered progressive sensory loss over the last 3-4 months, affecting the median nerve distribution in both arms. On examination, there is demonstrable sensory loss in the median nerve distribution, worse on the right than the left. There is peripheral hypopigmentation thickening along the length of the nerves. What is the diagnosis first? What is the diagnosis? What is the diagnosis? The diagnosis here is, all of you will know, this is leprosy. In PACES examination, that's why we are all advised. We are all advised. One examiner once reduced a mark for me in a mock examination conducted here some years back because I failed to palpate the nerve. So any peripheral neuropathy, PN means they used to tell palpate the nerve. PN, peripheral neuropathy means palpate the nerve. You should also know the enlarged nerves, mnemonic for the enlarged nerve. Where and all you will get enlarged nerve. Pertaining to MRCP, I made my own mnemonic called Helen. Okay, what are the thing? First is HSMN, hereditary sensory motor neuropathy, Charcot-Marie tooth disease. Next, A is for acromegaly, L for leprosy, A for amyloidosis, N for neurofibromatosis. All these places you will get an enlarged nerve. Okay, you will get nerve. You will get an enlarged nerve. But among all these things, here the one that suits is leprosy because of hypopigmented lesion. You have to do what biopsy here? You have to do a skin biopsy. Many will have jumped and wrote about nerve biopsy. What nerve biopsy will take? The first thing you will do is skin biopsy. Slit skin smear. Have you forgot during your MBBS? SSS, slit skin smear. It's the skin biopsy and not a nerve biopsy. Nerve biopsy is something very complicated. You won't do it. Leprosy is the first thing. The most useful is split skin smear. You have to see the lepra bacilli there, and you have to know the load, how many bacilli are there in that skin which you've taken for biopsy. That will guide your treatment and not nerve biopsy. You won't find the lepra running and walking around in the nerve, but in the skin you will find it. You have to take a sample of skin, you have to keep it, you have to study under the microscope. You should know the leprosy, the lepra load. So based on the lepra load, you will treat the patient. You will divide into multibacillary or a paucibacillary based on that, and you will give the treatment. All right, all of you got it? Okay, next question. 24-year-old rugby player comes to the clinic for review. He has 3 episodes of facial cellulitis with boil formation in his beard line. On the past 2 occasions, Staph aureus is isolated from boil swab. Which of the following toxin is Staph aureus most likely to be producing? Which of the following toxin Staph aureus most likely to be producing? A lot of responses are coming. A lot of responses are coming. So which is the toxin? Okay. This enterotoxin will cause food poison. All right. Enterotoxin will cause food poisoning. What is the problem here? Facial cellulitis and boils in the face. Am I right? Facial cellulitis and boils in the face. Let us know each and every option, why it is and what it is first. Okay. Enterotoxin will produce food poisoning because tomorrow they will give another scenario for you where a person who went and ate some barbecue in some restaurant and he started vomiting within 2 hours after eating the barbecue. That is Staphylococcus preform toxin. This enterotoxin will cause your food poisoning. Then what is given here? Hyaluronidase. Okay, hyaluronidase, your phospholipase C, all will help in invasion and penetration into the host tissue. Okay, invasion and penetration into the host tissue. TSST, you know what it causes. It causes toxic shock syndrome. This is an again invasive toxin. But this Panton Valentine leukocyte, okay, Panton Valentine leukocyte, this toxin is the one that causes skin infection, especially burns. Okay, mild infection you don't treat, but in a severe infection you have to here give fluoxetine. You have to give fluoxetine. All of you clear? In severe infection, you have to give fluoxetine. So you should know the individual toxin and what toxin and what it is worth, then you will be able to answer the question. Tomorrow they can give a toxic shock syndrome like scenario, and I will ask you which toxin is responsible for it or which organism is responsible for it. So in either way or every way, you should be able to answer. Next question, we will go to 56-year-old. Okay, 56-year-old women with 35-year-old history of type 1 diabetes mellitus comes to clinic for review. She has worsening pain and stiffness of her right thumb, coupled with thickening of skin over the palmar surface. Examination, there is a weakness of thumb apposition on the right hand side. And also examination reveals, on the left hand reveals normal power with no sensory loss. See the findings, anything is interesting. CRP is elevated, ESR is slightly raised. Glucose is 7.1, obviously she is a diabetic. Creatinine slightly deranged and nothing else is significant here. What is the most likely diagnosis? A diabetic patient is coming to you, pain in the right thumb with thickening of the skin over the right thumb. What do you call this? A, B, C, D, E. Is it psoriatic arthritis? Is it osteoarthritis? Rheumatoid arthritis? Is it a gout? If you know how all these things present, you will know rheumatoid arthritis, you know proximal interphalangeal joints. Psoriatic, it will cause either dactylitis and it will go for the distal joints. And osteoarthritis, you know how it is. It will form crepitus and there will be, it will affect morely the large joints. Gout, you know, acute presentation mostly affect the great toe. It can affect almost any joint, knee joint also, but it won't present just with pain and stiffness just on the right thumb and with thickening of skin over the palmar surface. It won't produce like that. Only thing that will produce pain and thickening of skin over the palmar surface is chorioarthropathy. This is seen in diabetes mellitus, in long-standing, uncontrolled, poorly controlled, worst controlled diabetes mellitus. All right. And this shows there is a presence of microvascular complications in this patient. Just see the fundus, there will be diabetic retinopathy, at least background retinopathy. If you test the lower limb, what is the first sensation that will be lost in diabetes if you do the sensory testing? Vibration sense would be gone, right? This is chorioarthropathy. Okay, next question. 22-year-old woman with a history of 3 previous paracetamol overdose over the past 2 years comes to emergency department. She is suffering from a rash which appeared overnight. On examination, there is a linear scarring with surrounding erythema on the flexural surface of both arms, behind both knees. Okay, routine blood test, including everything, is normal. What is the diagnosis and what is the diagnosis here? Okay, it's not pityriasis rosea. You know how pityriasis rosea. Psoriasis, it's not, because it's not some erythematous lesion alone. It will be plaque, should be there, and it won't appear overnight. It's not morphia either. Flexure eczema should have some scales and itchiness, everything should be there. This is a linear scarring. So what happens, people with a tendency to go ahead and overdose themselves with paracetamol or any other drug, they will have the concept or the phenomenon of hesitation cuts. Do you know what is a hesitation cuts? Okay, sometime maybe some person's boyfriend or a girlfriend is not picking up the call or maybe blocked them. They may have blocked them in social media or they may find them roaming around with somebody else. This gentleman or this lady will get upset. As a result, she will go to or he will go to his house, take the hand and maybe take a blade and they will mark cuts like this. Okay, this is called a hesitation cut. If you see in their hand, I'm teaching some psychiatry also here because the same question can come in psychiatry. Okay, that's the reason I'm just teaching you some psychiatry as well. All right. Okay, this thing is called as a hesitation cut. This cut you will find it's linear. It will be in the flexural surface of the hand because that's easy to go take a blade and cut. All right, this will be linear lines. It won't be all in the same shape. In the flexural surface, it's a hesitation cut. This is overall called your dermatitis artifacta. Dermatitis artifacta. This person doesn't need a dermatologist, but definitely needs a counselor and a psychiatrist, right? 32-year-old woman presents to the ED with a lesion in the left side of the lower abdomen. She says this is a raised lesion rapidly enlarged to become an ulcer. And there is a history of Crohn's disease. Although it's well controlled with systemic agents, on examination, you are seeing a 4 centimeter ulcerated area in the abdomen, abutting an ileostomy and has a bluish discoloration around the edge, a necrotic pus-filled core. Okay, this is somebody's abdomen. Ileostomy is done here. Around the area, you are finding a lesion like this, a rapidly enlarging ulcer with bluish discoloration around the edge with a necrotic pus-filled core. What is it called? What is it called? First, tell me what is it called? What is the diagnosis? Erythema marginatum. Who said that? Erythema marginatum is something called as your target lesions. It will be like a target. It won't form on a place where there is a previous ileostomy done. Okay. Here, this is called pyoderma gangrenosum. You should know the clues behind the lesion. First is an ulcerative colitis, sorry, Crohn's disease. That is an inflammatory bowel disease patient. It forms, IBD is a very high risk factor for it. Can also be seen in legs. It is associated with other autoimmune arthritis and other autoimmune conditions also. Okay, it forms as an ulcer. Typically, it will have a pus-filled core and a bluish discoloration. All this suggests pyoderma gangrenosum. Okay, if you get all these pointers, it should point you towards pyoderma gangrenosum. Now, what is the next thing you will do for this patient? What is the next thing you will do for the patient? A, B, C, D, E. What you are going to do? You're going to give a steroid, you will tacrolimus, you will do patch testing, you will do wound debridement, you will give cyclosporin. I know I'm going to get a wide variety of answers. You will not debride this lesion. Okay? Remember, you will not debride this lesion. Okay, it's a very, very important topic. I should pay some careful attention. Pyoderma gangrenosum. Okay, this is a very, very important topic. So all of you should know about this. Okay, pyoderma gangrenosum is a very, very, very important topic. The very first thing you have to give here in this person, okay, in this gentleman is topical agents. The best bet is tacrolimus. Okay, the best bet is your tacrolimus. Tacrolimus is the very first lesion very first treatment you are going to start. Tacrolimus is the very first agent you are going to start. Then you can try so many agents, okay? Then you can try so many agents, including your dapsone and other things. First thing, you have to give a topical tacrolimus. All right? Okay. Yes. We'll go to the next MCQ. 62-year-old man who has recently been diagnosed with bronchial carcinoma. Everything is important when it comes to an exam. MCQ. He is diagnosed with bronchial carcinoma. He is coming to dermatology clinic. He began to suffer a number of painful mouth ulcers and a generalized blistering, itchy skin rash. On examination, his BP is 132/80, pulse is 82 beats per minute, and regular. There are decreased breath sounds, of course, due to the lung carcinoma. On examination reveals widespread tense blisters. Okay, and in various skin and mucosal sites. What is the diagnosis? What is the diagnosis? What is the diagnosis? First, you should know the diagnosis. If you know the diagnosis, then you will tell the answer. Somebody who is a cancer patient, somebody so close, bullous pemphigoid, it's a pemphigus, not a pemphigoid, okay? Because mucosal sites, mouth ulcer, bullous pemphigoid will not involve the mouth, okay? In my dermatology core concept lecture, I had clearly described the difference between a pemphigoid and a pemphigus, okay? So what is it? In a patient who is having a cancer, if pemphigus is present, it is called as your paraneoplastic pemphigus. Okay, paraneoplastic pemphigus. All right, it's called paraneoplastic pemphigus. All of you convinced? Now they are asking which antibody is associated with this. You know, C. anca, Wagner's granulomatosis. You should know. Option-wise ruling out. 2. E. Tissue transglutaminase, celiac disease. Anti-Hu, anti-Rho antibody is associated with paraneoplastic peripheral neuropathy or even your paraneoplastic cerebellar degeneration. Done. What is left? The answer is B. Anti-Envoplakin. Another antibody is bullous pemphigoid antigen 1, BPA1. Another antibody associated here is desmoplakin 1 and 2. Another antibody associated is plectin. All this you should know. These are all the causes of paraneoplastic pemphigus. Paraneoplastic pemphigus. All of you should be aware of that. Okay? All of you should be aware of that. Next question. 56-year-old man with a history of psoriasis comes to dermatology clinic for review. He's taking a number of medications for hypertension and he has endeavored to get a under control for the past 4 months. Unfortunately, there is worsening of psoriasis. They are asking which of the following agent will cause worsening of psoriasis? A, B, C, D, E. Drug-induced psoriasis, drug that is worsening psoriasis. There's a huge list. Okay, here you know beta blocker can worsen. Along with that, you should also know lithium can worsen psoriasis. Anti-malarials can worsen psoriasis. Your NSAIDs can worsen psoriasis. All the drugs, okay? All the drugs that leads to psoriasis, that can induce psoriasis, everything you should know, okay? Everything is you should know. Lot of drugs. You know, your benzodiazepines can do. ACE inhibitors can do. Interferons can do. Terbinafine can do. The list is just huge. Okay, the list is just huge. You should be able to know what are the drugs that induce psoriasis. Next question. Which of the following is a feature of Sézary syndrome? Before that, you should know what is Sézary syndrome. What is Sézary syndrome? Sézary syndrome is a cutaneous T cell lymphoma. It is also another subtype. Another subtype is what we call overlap subtype is called mycosis fungoides. Okay, this is a T cell malignancy. It's a know it or know it not. If you know what is it, you will know the answer. Okay, right? This is a cutaneous T cell malignancy. So worst prognosis. One of my friend's father had it, and my friend who is he himself is an ID physician, a very big clinical practice, and during COVID time, he has been interviewed by big channels, including BBC. His own father had it. And in the last moments, it is very unsightly appearance he has become into. I just don't know why God allows such things to some people. It's really horrible. To such a good person, very humble person is died, suffered a lot, and he passed away with this T cell malignancy. This is a cesarean. Next question. 55-year-old woman suffered from primary biliary cirrhosis. She now complains of some rash over her wrist and ankles. She has recently seen by a gastroenterologist who has told her to continue polystramine, which she had been taking for 3 years. Examination shows purplish polygonal flat papules on her wrist and ankles, fine white lacy network in her mouth. What is it? Straightforward question. The fine white lacy network in the mouth is called your Wickham's. Believe my spelling is right. Wickham's striatum. This is a lichen planus. All piece of lichen planus are told here. This is a case of a lichen planus. All of you will be knowing this is a case of a lichen planus. Far straightforward. All right, the next question. 25-year-old pregnant woman complains of painful bumps, lumps in the shin. She's 32 weeks pregnant, suffers from asthma. Examination shows tender red nodules over the shin. What is it called? Tender red nodules over the shin. There is only one diagnosis where they find tender red. Everything in MRCP is like MRCP 1 and 2 is connecting the dots. If you prepare properly, you will never fail in MRCP 1 and 2. PACES is not like that. PACES is evaluated by humans. There are human errors. There are human bias. Okay. Somebody who knows medicine in and out really well can fail in PACES. One candidate I will tell you, he is a professor of medicine for 30 years. Okay. Gold medalist in his MBBS in general medicine, gold medalist in MD general medicine, and national level medicine, gold medalist in MD general medicine, PhD in general medicine, MSc in general medicine, again a gold medalist in MSc Edinburgh paper. Okay, the best student and the best candidate award from JRCTB. All right, best candidate from JRCTB. He went and failed PACES miserably. Nobody knows why. He told the answers correct, but something in the examiners didn't like in the way he told or whatever. I don't know. He's not an arguing type of person either. On the same time, I met another guy who came to prepare PACES for just like 1 month before the examination. He is a dermatologist. Okay. The day he came, I took him to a patient in our hospital and I told him, please go ahead and examine him. Okay. He went, he examined, he came back and asked, is it a systolic murmur or a diastolic murmur? How systolic murmur sound, how diastolic murmur sound, just 1 month before PACES examination. Dermatologist. You won't believe he scored 170 out of 172 in 1 month, not because of my teaching, nothing to tell, because I just taught him around for hardly 3-4 days, and after that he just roamed around, and out of his luck, he scored like that. Another guy, anesthetist, he doesn't even know what is a long track, how to elicit a knee reflex, where to hold a knee hammer. I thought this guy is Kadam. He scored 95% and cleared 15 days of preparation. That is PACES. But MRCP 1 and 2 is not that. You should know the connect the dots. There are some dots here. If you know to connect the dots, you will find the answer. That's it. No one can stop you from failing. That is the beauty of MRCP 1 and 2 and USMLE examination. USMLE is very fair. Same thing. No to connect the dots, you will pass. PLAB, same thing. Australian Medical Council exam, same thing. But the PACES examination is something terrible injustice to any doctor. The people with the best experience fail, and the people who just start and randomly go blubber pass. It's because of examiner variation and the center variation, your language, everything comes into play there. So MRCP 1 and 2, no excuse to fail. I'm not being rude, I'm telling you the fact. Okay, no excuse to fail in MRCP 1 and 2. You should clear with full marks. All right. Now see, what is the dot I want you to connect? What are the things here? Someone pregnant. See, these are the dots. These are the keywords. If you connect the keywords, you will get in a pregnant lady, in her shin, there is tender red nodules. Every word is important. If you connect all this nodule, all these points, there is only one diagnosis. What is the diagnosis? That diagnosis is erythema nodosum. Okay, cellulitis. Cellulitis, how it presents? It won't present like a nodule. If it is her legs, this entire area will become red. This is a cellulitis, right? And there will be some systemic findings also will be there. Drug eruption. What drug she is taking? Nothing like that. She is just taking, she is an asthmatic and she is just using inhalers. There is no chance of getting a drug eruption. Erythema multiforme, you know, target lesions will be there. And the name itself says erythema multiforme means multiple forms will be there. Now then comes granulomannulare. This is more common in diabetes mellitus. What is the name of the lesion? Granuloma. It is a granulomatous lesion and annulare. Annular means round circle form. Okay. So all the options ruled out. Are you getting it? The answer is erythema nodosum. All right. Next question. 55-year-old man has non-infective necrotizing ulcers in lower lip. A diagnosis of pyoderma gangrenosum is made. This is a very favorite question for examiners. He is currently being investigated for lower back pain. Which of the following underlying conditions is associated with pyoderma gangrenosum? A, B, C, D, E. Lot of conditions can be associated with pyoderma gangrenosum. Among all these things, which of the following is the most common? They are asking among the following which is most common. Hemochromatosis is not associated with pyoderma gangrenosum. Hemochromatosis is associated with something called as pseudo-gout. Heard of it? CPPD. What is that? CPPD means calcium pyrophosphate deposition disease. Gout is not certainly associated with that. Autoimmune thrombocytopenia also not. Sometimes NHL, rarely it is, but among D and E, multiple myeloma is most commonly associated than NHL with pyoderma gangrenosum. Okay, multiple myeloma is most commonly associated with pyoderma gangrenosum than NHL. Next question. 30-year-old man gives a history of recurrent blistering of hands and forearms and chest whenever he is on holiday during sun exposure. There are numerous scars in the same area. He is a fit man working as an interior decorator. He drinks 30 to 40 units of alcohol per week. You all know what is the diagnosis. We have discussed. Definitely, it's not light eruption or sunburn. None of them will produce scars. Tremendous scar. It's not pemphigus vulgaris or bullous pemphigoid because this will produce blistering lesion and involves oral cavity. Bullous pemphigoid is a bullous lesion. Nothing like that we are seeing here. This is a porphyria cutaneata. You should know the alcohol limits. Okay, 14 units now. 14 units per week in UK. For both men and women and all the other sexes, they added LGBT, EF, GH, HI, U, whatever it is. For everyone together, it is 14 units. Sorry. 33-year-old woman reports that some of her nails has been changed. Which of the following is the most associated with onycholysis? Onycholysis is destruction of the nails. Which of the following is associated with onycholysis? Onycholysis, that is destruction of the nails. Which of the following is associated with onycholysis? That is destruction of the nails. Which of the following? Onycholysis can have a lot of cause. Okay, onychomycosis can cause. Psoriasis can cause. Trauma can cause. Infection can cause, especially Pseudomonas infection of neck. Fungal infection, most common, can cause. All right. So many causes are there for onycholysis. All right. Even in Reiter syndrome, there can be onycholysis. So many causes. So which is the following? Which of the following is the cause of onychomycosis? Yes, it's associated with psoriasis. That's what I've written here. Among the following, the notorious thing that can cause onychomycosis is none other than your good old doxycycline. This is notorious to cause onychomycosis. Here, you should be knowing other adverse effect of onychomycosis. You know, arsenic poisoning, it's not a pemphigoid, it's not a blistering lesion or a bullous lesion. Arsenic poisoning will not cause that. Mycoplasma pneumonia won't. Okay, mycoplasma pneumonia. Pityriasis rosea, that's not the option. Which of the following feature is most suggestive of a melanoma? You should know what is a melanoma and how melanoma occurs. Then you will know which of the following is a suggestive of melanoma. You know something called A, B, C, D, E of melanoma? First thing is asymmetry. B is border irregularity. C is color change. D is the depth of the lesion and E is evolving. What is here matching? C, color change. Multiple colors. New central elevation. No, it will be rather deep going lesion. It won't centrally elevate. Not the depigmentation around the periphery, rather the change in the shape in the periphery. No cobblestoning, no bleeding. The answer is multiple colors. They will also ask the prognosis of the melanoma is based on this Breslow's grading. Based on the depth, it's called Breslow's grading. They had asked a couple of times. Okay, they had asked this a couple of times. 55-year-old man complains of nausea, loss of appetite, and dyspepsia for meals for the last 2 weeks. He is a smoker and he has a past history of pernicious anemia. He is pale, cachectic, tender at the epigastrium. Could be some gastric cancer. That's like it is going on like that, the direction of a gastric cancer. He has velvety skin and hyperpigmented skin at the neck and axillary fold. What is it? Straightforward diagnosis. You know, this is your good old acanthosis nigricans. Okay, it is associated with diabetes mellitus, it is associated with gastric cancer, it is associated with Cushing syndrome. So huge list is there. Nothing you can do. You can treat the underlying conditions. You can try some topical medications, but it's not going to be of any help. You have to treat the underlying condition. 44-year-old woman has been admitted to the hospital with a pneumonia. She has now developed a rash on the palms and soles made of lesions with concentric erythematous ring. She also complains of painful mouth ulcers. How to connect the dot? Mouth ulcer, pneumonia, and they are talking about a lesion as a concentric erythematous rings. This lesion is called erythema multiforme. Now connect the dot. Mouth ulcer, pneumonia, and erythema multiforme is what pneumonia? Mycoplasma pneumonia. And the diagnosis is erythema multiforme. Erythema nodosum, you know it presents in the shins. Fixed drug eruption will present differently. Pemphigus vulgaris, you know it should involve the oral cavity and also other parts of the body. Toxic epidermal necrolysis, widespread peeling of the skin. It will also affect all the mucous membrane and the patient will be septic. Okay, the patient will be septic. Which of the following is true regarding psoriasis? That is the question. A, B, C, D, E. Psoriatic arthropathy occurs in over 70% of the people with psoriasis. No, sir, it won't. Okay, many people will have just psoriasis alone without formation of arthropathy, not 70%, definitely. It usually improves after infection with HIV, definitely not. It will actually worsens. It suggests abdominal malignancy. No. It affects 4 to 8% of the world population. Again, these numbers are wrong. No. It is an independent risk factor for cardiovascular disease. Yes. Psoriasis, psoriatic arthropathy, rheumatoid arthropathy, all these things are independent risk factor for ischemic heart disease. Remember, all these things are independent risk factor for ischemic heart disease. 23-year-old woman has acne vulgaris. She only used OTC face wash. She is 20 weeks pregnant. What medication you will give her? So first thing, how to rule out the option A, B, C, D, E. C, which is a teratogenic drug in pregnancy. You will not give that. Okay. So what are the teratogenic drugs here? Isotretinoin and retinoid cream are teratogenic. You are not going to give in pregnancy. Done. Doxycycline contraindicated in pregnancy. Now you are left with two options. You are left with two options. Doxycycline is contraindicated in pregnancy. Whoever answering C, please know the list of drugs that are contraindicated in pregnancy. Okay. Moderate potency topical steroid or benzoyl peroxide with clindamycin. If you had seen my acne lecture with nice guidelines, I had explained to you the first line in pregnancy is benzoyl peroxide and clindamycin gel for 3 to 6 months. This is the most appropriate first line for the management. This is the most appropriate first line for the management. 25-year-old man presents with well-defined patch of hair loss on the scalp, surrounded by exclamation hair mark. These are the dots. Exclamation hair mark is characteristic feature of one particular type of hair loss. This is the pathognomic of one particular type of hair loss. What is it? It is called, what's it called? Like this. Anybody? Anyone? Exclamation mark hairs are only seen, or if you're finding exclamation mark hair in a question paper in for MRCP 1 and 2, it is alopecia areata. Okay. Trichotillomania is a psychiatric condition where they pull the hairs out. It's not the answer. Tinea is not the answer. There will be associated skin changes in the scalp also. Telogen effluvium will not be a patch of hair loss. It will be a hair loss here and there and everywhere. Discoid lupus erythematosus is not the answer again because it will cause a scarring alopecia. Scalp skin here appears normal. So it's a non-scarring alopecia. A patch of hair loss with exclamation marks is alopecia areata. This alopecia areata can be divided into two. That is universalis and totalis. Totalis is means what is only the head scalp hair is gone. Universalis means they won't have hair anywhere in any part of the body. No part of the body, nowhere they will have this. Okay. Nowhere they will have this. That is universalis. The treatment includes a lot of things. And when it comes to alopecia areata, it is associated with a myriad of autoimmune disorders. Myriad of autoimmune disorders, not one or two, lot of autoimmune disorders. You have to rule out rheumatoid arthritis, type 1 diabetes mellitus, myasthenia gravis, pernicious anemia, hyperthyroidism, so many autoimmune disorders. There's a lot of treatment. You can give some hair patch. You can suggest some wig. You can suggest intralesional steroids. All these things you can suggest. But among all of them, the most important latest drug is JAK inhibitor. What is meant by JAK? Janus kinase inhibitor called vorticimab is used. All these things you should know. If you know all these things beforehand, 1 second you will answer, and whatever question they can ask, you can answer. They may next question they can ask. They won't ask what is the most likely diagnosis. In this place, they can ask which of the following condition is associated with this. And you should be able to tell. Type 1 diabetes mellitus. You might not know. You should be telling. All right. This is alopecia areata. Coming to the next question. Okay. 46-year-old man complains of facial redness. Examination shows macular erythema with prominent telangiectasia over the cheeks and nose. He also has papules and pustules on the nose and chin. What is it called? Telangiectasia, facial redness, especially in a man in middle age. In middle age, they may give you or may not give you. It's getting worsened when he drinks alcohol. Anyone? Excellent. Yes, this is rosacea. Okay, this is rosacea. Okay, rosacea. Treatment is avoid alcohol, and you can give topical metronidazole. Next question. 35-year-old women presents with yellowish mottling, overlying goosebumps on the skin over the neck. Skin appears puckered. This is called a chicken skin. Chicken skin. Puckered skin. And she also has mitral valve prolapse. What is the likely diagnosis? What is the likely diagnosis? Yellowish skin, especially around the neck. A puckered skin associated with mitral valve prolapse. Ehlers-Danlos syndrome, there will be joint laxity all over the joints and skin laxity all over the body, not just in one place. So it's not the answer. Marfan syndrome, the person should be tall, fingers should be elongated, Walker-Woodrock sign, thumb sign positive, high arched palate. It's not the answer. Necrobiosis lipotica diabetica is seen. Xanthum and disseminatum will not present like this, but here only peculiarly around the neck with the mitral valve prolapse is a pseudoxanthoma. Right? Now comes a 32-year-old man presents with painful mouth sores, painful red eye, polyarthralgia. These 3 points with the recurrent painful genital ulcers. What is the diagnosis? It's a triad of finding. Okay. Mouth, genital ulcer, painful red eye, could be some uveitis, and then joint pain, polyarthralgia. There is only one diagnosis that fits all this, that is your Behçet syndrome. None of the other things will present like that, you know. These are connecting the dots. You connect the dots, you will get the answers in reactive arthritis. Reactive arthritis, you won't get ulcers in the genital. Rather than you will get urethritis, painful urine, burning micturition, pus discharge while passing urine. Those are the symptoms you will get, but not the ulcers. 75-year-old man presents with pigmented lesion and malignant melanoma is diagnosed. What is the thing that determines the prognosis? I had told you just now. What is the thing that determines the prognosis is, I said, what is that? Breslow's grading. Depth. That is the depth of the tumor. How deep is the tumor? How worse is the prognosis, or how better is the prognosis? We see. 30-year-old female returning from Brazil developed a non-healing ulcer on the left ankle. She had spent 2 weeks camping in the jungle where she'd been bitten by flies. We all know this is a cutaneous leishmaniasis. Which of the following statement is true? Cutaneous leishmaniasis frequently precedes Kala-Azar? Absolutely not. Usually responds to oral penicillin? No. Transmitted by boat fly. Is it a boat fly or what fly is that? It's called a sand fly. Sand fly. This is a sand fly. Lesions of leishmaniasis, America's requires treatment due to the risk of mucosal disease. Mosquito nets are important in the prevalence. No, mosquito nets will not prevent sand flies. But lesion, which is there in places like America, as a widespread mucocutaneous disease compared to the lesion in the old world or other places. So they require treatment due to the risk of mucosal penetration. Okay, due to the risk of mucosal penetration, especially the American leishmaniasis requires mucocutaneous. We can go for a mucocutaneous presentation. So you may have to give here something like that of a sodium stibogluconate. This question can come in any form, so be ready. Okay, that's why I will tell people stop memorizing notes. Stop memorizing notes. Stop memorizing anybody's notes, which is of going to be no use. Because once they twist the question little, you are finished. If they twist the question little, you are finished. All right. Now comes to the next question. A general practitioner is called to a nursing home to treat a 75-year-old man with severe pruritus. He has a background of advanced vascular dementia. He is unable to give a history. Nurses report he is often awake and itches his skin at night. On examination, he has excoriation over his trunk, limbs, and scaling over his palms, most prominently on the web spaces. Now tell me what is the diagnosis, then we will go for the treatment. This is a very common condition. Somebody is coming and doctors, please type in the chat instead of using the audio, because this is a recorded lecture. It's going across different countries and to different people. Okay, and somebody having a rash over the scaling in the palms and in the trunks, in the limbs, in the web spaces, and you can even tell this gentleman may be having a rash in the genitals also. This is a scabies. So what is the treatment for scabies? I believe all of you will be knowing. All of you will be knowing. What is the treatment for scabies? He will give a topical permethrin. Okay, topical permethrin. If it is not working, somebody said Norwegian scabies. What is a Norwegian scabies? Norwegian scabies will be a crusting will be there. It's called a crusted scabies. It is more widespread. It is more risky. It is more risky. Okay, I took a permethrin shower 2 weeks back because there was an MND patient. I didn't know that was a scabies. My another senior doctor called to go out and examine that lady. Then in some rush, I went and examined her. Then I realized I was touching her. She is having a crusted scabies all over. It is also infected scabies. Then I know I'm gone. Then I immediately got the lotion. I took a shower for 2 days and even gave for my kid also, so that nobody else gets affected. Scabies is like that. Easily it can spread from one person to other person. That's why you have to treat the entire family. Crusted scabies, excellent doctor. You will use ivermectin. Which of the following drug is most likely to have induced photosensitivity? That is a question. We have worked out this question, okay? So we need not wait here for quite a long time. The drug that induces photosensitivity here is your doxycycline. Drug that induces photosensitivity is here, doxycycline. Next question. 45-year-old woman presents with mouth ulceration and target lesions. So erythema multiforme is diagnosed. This is associated with which of the following? A, B, C, D. This is a know it or know it not question. You know it, you will answer. If you don't know it, you cannot answer the question. Like that question. This is a know it or know it not question. Erythema multiforme is also associated along with mycoplasma pneumonia. It's also associated with your herpes simplex infection. It's not associated with any of this infection. All right. Then comes your 75-year-old man presents to the GP complaining of a lesion on his nose. Examination confirms a well-defined 8 mm shiny pink plug. Okay. Prominent surface telangiectasia and a small central scab. If anyone would have attended my core lecture on dermatology, you will easily find it because I have shown the pictures. So many pictures I have shown about this. Shiny plug, prominent surface telangiectasia in the nose. This is called also rodent ulcer. Why? This keeps going like that. This is your good old basal cell carcinoma. Basal cell carcinoma. Next question. A 78-year-old man with chronic venous insufficiency presents with a well-demarcated area of intense erythema of left leg. There is induration and raised border. What organism is responsible for this? First, you should know what it's called. Somebody with a chronic venous insufficiency. Well-demarcated area of intense erythema. See, this is the leg. A well-demarcated area of intense erythema. Okay, here it's an intense erythema. In a well-demarcated area. It is raised, it is indurated. So this is a kind of what? This is a kind of cellulitis. This is a kind of superficial cellulitis. In the leg, typically, in the leg, especially people with venous insufficiency occurs, it can be due to something called erysipelas. Excellent. Got it. Erysipelas. This erysipelas is typically due to which organism? Streptococcus pyogenes or a group A beta hemolytic streptococcus. Okay, this is a know it or know it not question. Treatment of choices here you have to give penicillins. Oral penicillin, all right. Oral penicillin. Scalded skin syndrome is entirely different. What is the name itself will tell? It will be widespread. Here that's here the entire lesion is confined to his leg. Okay, it is confined to his leg. Next question. 54-year-old woman visits a GP with a skin rash that has appeared a few days after commencing clarithromycin for a lower respiratory tract infection. She has a multiple circular lesion varying in size with 3 different shades of red. Most of the lesions are on the hands and feet. Some of the palmar lesions are blistering centrally. There is only one diagnosis for this definition. What is it called? Only one diagnosis for this. A, B, C, D, E. What is the diagnosis here, doctors? Non-drug eruption. That is where they keep a pit. These are red herrings. Right? These are red herrings. These are red herrings. There is only one lesion that can proceed. This is erythema multiforme. Before calling it as a bullous drug eruption, some people are marking A. Where is a bullous here? Where is a bullous lesion here? Anywhere is it mentioned? It is a bullous lesion. Dermatology, see, MRCP is like my mentor and my guide throughout my 3 years of medicine residency, Dr. Mahendra. I hope all of you know. He used to tell me one thing. You know English, you will know medicine. Most of the answers are English based. Simple. Bullous. Is there anything bullous here? Nothing. Rule it out. Erythema nodosum. What is mean nodosum? Nodular lesion. Anything nodular? Rule it out. Granuloma annulare. Circular lesion. Yes, it can be. Is it granulomatous? No. Rule it out. You don't need to even know medicine to rule out options here. Just English words, then you can rule out and you can keep. This is an erythema multiforme. Okay, erythema multiforme. Could have clarithromycin could have been started for mycoplasma pneumonia in this particular case. They can twist and ask the question in that form also. All right. 34-year-old man presents to his GP with a rash on his leg. On examination, there is number of discrete tender red nodules. Yeah, now you tell. This is like a no English, no medicine question. Okay, you know English, you will know medicine. Red nodules. What is the answer? What is a nodular lesion? In ABCDE, what is a nodular lesion? Who is answering insect bites? No. What is a nodular lesion in ABCDE? There is only one nodular lesion. Where it is put? It's B, erythema nodosum. End of the story. Erysipelas is a cellulitic-like picture. It's not a vasculitic lesion. Post-traumatic ecchymosis. Where it says there is a trauma here? We don't know. Right? There's no trauma. Nobody says there is a trauma here, right? Nobody says there is a trauma here. This is a erythema nodosum. Okay? This is a erythema nodosum. 23-year-old man visits local GP while on holiday in the UK from Australia. He noted a lesion on his penis, which was initially nodular and painless, but has progressed over time to form a heaped up ulcer. Sampling from the lesion contains mononuclear cell containing many Donovan bodies. Donovan bodies, right? What is the diagnosis? Painless heaped up ulcer in penis. And there are Donovan bodies. This lesion is also known as donovenosis. What is it called? It's not a penile carcinoma. This is not a age to develop penile carcinoma. Okay, this is not a age to develop penile carcinoma. It's a 23-year-old guy. Nothing says there is no lymphadenopathy. There is no associated B symptoms of a carcinoma. Nothing is there. So you can rule out penile carcinoma out. It's not genital herpes. Why? Herpes will present as a group of vesicular lesion, not as a single lesion. So genital herpes is out. It is not chancroid. Chancroid is something that will cause a painful ulcer. All right. It's not lymphogranuloma venereum. It doesn't present like this. It will present with additional inguinal lymphadenopathy and other lymphadenopathy. Here, the only thing that has a Donovan body is a painless heaped up ulcer is an infection due to an organism called Klebsiella granulomatosis. And that infection due to this organism is granuloma inguinale. These are knowing or knowing not question. You know it, you will answer. You don't know, you won't answer. Okay. These are know it or know it not question. All right. This is granuloma inguinale. Okay. All right. Thank you so much for attending the session. With this, I'm winding this up because it's already pretty late. And thank you everyone for participating here. And please leave your valuable feedbacks in the group. And the set of other dermatology lesion will be covered for all the subscribers from tomorrow after working out some ID questions have been left for them. And for all the others, and we'll have another free session on ulcerative colitis. And I think today is Tuesday. Wednesday leave because Wednesday I have to have some couple of lectures for the subscribed students. And Thursday we will have a session on ulcerative colitis. And Friday, if there is a possibility, I'll take a section. I'll take a section on stroke, nice guidelines and stroke. Thursday I will try a lecture. Okay, I'll definitely come and teach you, clear your doubts. And somebody asked on insulin therapy, definitely I'll do that. Okay. Definitely, I will do that. And someone asked on pyramidal and extrapyramidal cracks, that is anatomy that we will do with the basic sciences. Okay. Now we are more concerning the clinical sciences, clinical oriented thing. Okay. Thank you so much for attending. That will be reminded. If you want to join us for a good journey on MRCP 1 and 2 or 4 cases, please let us know. We are more than happy. If you are around my place, you want to come with me, see some cases, you are more than welcome for a tea or coffee. I won't bite you, don't worry. All right. And thank you so much. And we are here to help you. God bless you. Bye-bye. Please leave your valuable feedbacks in the groups you are coming from. Different people are there in different groups. Please leave your feedbacks and leave your difficulties. What thing you are facing difficulty in any part of MRCP, 1, 2 or cases whatsoever. We are more than happy to help you. Thank you all. Thank you so much. Good night and God bless.